Can you see my screen, please?
Yes, sir.
You can see my screen?
Yes, sir, we can see, sir.
Okay. I think I've changed to previous slide. Okay. So good afternoon once again, everybody. So I think my role is coming when there is a failure to your fixation, or the patients where the fixation is really difficult, or the fixation you predict that is not going to have a better fixation. As you know that trochanteric fractures, the gold standard is for the osteosynthesis, because as long as the joint is good and there is no pain in the hip joint, we should attempt to fix the fracture, or even there is some malunion, you can go for osteotomies, as Dr. Suman has explained, and there are so many osteotomies are there. So the gold standard is always a fixation of the trochanter. Then why there is a need for replacement in IT fracture? As you know that from our PG days, we have learned that the IT fracture should be fixed. The implants may be varying from day to day, and it has evolved from so many fixation devices to as on today, and there are multiple nails, multiple plates are available. But still, there is a place for replacement. So it is surely based on the advantage of arthroplasty or the disadvantage of osteosynthesis. And this basically caters to a few group of population where you find that the fixation is really not going to give outcome, or the time for osteosynthesis or time for the union of the fracture is very long to give a benefit to the patient who couldn't get a better lifestyle or better quality of life with just arthroplasty. So just look at this particular patient and you find this patient is a IT fracture, something near about 90 years. So what will be your attempt in this particular case? So definitely I can say that you want to get away with the surgery as early as possible. The fracture has a very less chance of like union. Maybe I cannot say that men will not unite, but the union chance will at its own time. And during that time, looking at the quality of bone, I don't know how early we can allow weight bearing. So making the patient or putting the patient on bed or preventing weight bearing, you know, they right now sees on a lot of these medicaments and some tubes in the ICU. So definitely we want that this patient should work as early as possible. So that is the motto when we shift from fixation to replacement. The disadvantage of osteosynthesis in some particular group of patients is like how much time it will take to unite, because we don't have a time like 3 months, 6 months, then later on we go for osteotomy to unite. This subgroup of population who are really frail, who are very old, and the bone quality is very bad, in those patients, the union also becomes much difficult. And it has happened that these patients, their trochanter never unite. And it may end up with a implant failure or screw cutout, or many things can happen. And you need to immobilize patients for to get a union faster, but at the cost of some comorbidities, lung complications, bed sores, so many things. And few patients, their life expectancy is less than the time what is needed for union in these particular patients. So these are the few reasons why we thought of going for a replacement. Looking at this fracture, just imagine this is a very good looking x-ray and sorry. So everybody find that the fixation is very good. But looking at the quality of the bone, the screw has completely back out. So the time which has been explored or spent for this particular stage to happen, the patient has undergone a lot of stress, lot of immobilization, but at the end, we find this scenario. So that is the reason why I say some patients are fit for replacement rather than fixation. The advantage of arthroplasty is basically for there is no need for union, there is immediate weight bearing and better vital returns. The approach can be transtrochanteric or your routine approach like anterolateral or posterolateral, whatever you feel comfortable for you. But transtrochanteric decreases the further soft tissue release. So many times this gives a direct access to the head of the femur and allows removal of the head of the femur for replacement. But the challenges are because the lesser trochanter is gone, there may be loss of comminution. The version is very much difficult to assess. The limb length, because many times this tissue are frail, there is always a tendency to give a higher offset neck so that you can give a good capsular strength so that there is less chance of dislocation and varus collapse, preventing varus collapse. So they are the few challenges in particular patients. The surgical tips for this particular patient were planning for replacement. I prefer to go for a cemented femoral stem because there is no time for integration of the bone to the stem. And you can reinforce the calcar by some bone fragments to prevent varus collapse. Prophylactic wiring at the lesser trochanter area and also the GT fixation is very much vital for the outcome of the procedure. This trochanter fixation can be done either by the tension band wiring or you can use some trochanteric hook plates, or as such you find the bone quality is very bad, you can use a cracker sutures to fix this abductors to the shaft of the femur. So looking at the few of the literatures, one study where they have gone for cementless hip arthroplasty and the mean time for weight bearing was 47 days. So it will gone up to 79 days equivalent to nearly 3 months. So this can be avoided by going for a cemented stem. There are also cases of periprosthetic femoral fracture. There are also postoperative dislocation, though there was improvement in Harris hip score. In another study, they found that the mortality risks of primary cemented arthroplasty did not differ significantly from those dynamic hip screw or PFN. But they also mentioned that it is a viable treatment option for trochanteric fractures if osteoporosis prevent from full weight bearing or if the osteoarthritis makes further operation likely. So there are variable studies who have different of opinion. And in another survey in Turkey, in taking care of 159 orthopods, they found that the orthopods prefers 24% for patient having 71 years to go for replacement, and 8.4% of orthopods prefer to go for replacement in 50 to 70 years. So it shows that as the age goes up, the more of indication is for arthroplasty. So this is what also in my scenario, like maybe 71 is little early, but I will be more towards 80s. In another study, they found that the mortality rate was 17.94% 1 year and almost goes about to 83% 10 years and 5 years 56%. So half of the people will be dying when doing this procedure. So what I mean to say that, so instead of going for osteosynthesis, because I know that these patients will die for some or other reason of comorbidity, there are other vital conditions. This hemiarthroplasty or hip replacement is for your competency, I think will give a better outcome to these patients. This is one of the meta-analysis which found that the cemented biper hemiarthroplasty and cementless, but they found limb length discrepancy was more with cemented group. But I think this was a meta-analysis and there is some study bias because the surgeon might have gone for cemented in those cases where the bone was more porotic. And in those patients that capsule also lacks, the patient must be more frail. So in this patient, they have a high chance of lengthening. Rather than cemented would be having a reason for limb length discrepancy, but it is a study of meta-analysis of 31 studies. So I respect this study, but the reason could be this one. But I don't find any reason that why cemented should have a more chance of limb length discrepancy than an uncemented one. So this is one patient where you can find that 61 a female, and we could have gone for, because the joint is also affected, there is no reason to fix it, so straightforwardly go for a replacement. What I need like to focus here is we need to fix the lesser trochanter fragment to prevent varus collapse, and also the trochanteric wiring, that is very much important for a good abductor function. The another case of 72 years female What a flail lady. So we have gone for a cemented bipolar, but most important is fixation of the GT. Unless we have a fixation of GT, there is high chance of dislocation, and also there could be high chances of other complications of poor lurching, and you can have also like a migration of the GT, and the patient may not have a good walking capacity. So there are certain concerns like intraoperative lax of the joint because of the flail lady and their soft capsule, and also the muscles are the flail. So it is better to have distalize the trochanter and reinforce the abductors, all the capsule, rather than just increasing the offset. The version, yes, we can have other ways of looking at the version rather than the neck and the lesser trochanter. You can look at the leg position, and accordingly you can adjust the version. Intraoperative fractures, it may happen, rather it really do happen. So I can ask for having all the armamentarium to manage whenever there's a fracture occurs. And to prevent a fracture, we need to go for wiring, prophylactic wiring at the lesser trochanter, and also to keep the other instruments if there any occurs chance of any further fractures of or any extension of the fragments. So take home message like I will always think of taking a second opinion whenever I just go beyond osteosynthesis and plan for replacement. And younger patients, definitely I will look for osteosynthesis, or I will go for multiple surgeries, osteotomies, rather than going for replacement. But unstable IT fractures, fail patients, bone problem, I will prefer to go for cemented replacement. Treat each patient individually. Follow the literature, but definitely decision of yours is the best because you have to treat each patient individually. So before closing, I have this patient lined up for surgery. She is 97 years and this is the X-ray. I would like to ask the panelist what would be the plan this particular patient, because the joint looks pretty good. I cannot think of replacing the joint and the fragment is so bad. So, and the patient is 97 years. Please give your opinion. Rather, should we fix it or replace it? With that, I thank you very much. Have a good day.